Good evening, everyone. So welcome to the webinar series by IITACB. So just to inform you that last week we inaugurated a center at Boom Center, Bangalore. And as we all know that the center provides a unique networking platform to establish a collaboration between academia and the industries through the projects of national importance. So all are welcome to connect. And so today we have an interesting topic on cutting edge technology in healthcare and its future prospects in next decades. So our speaker is Dr. Krishnan Ganapathy. So a brief about the Dr. Ganapathy is he obtained his master's degree in neurosurgery, and then he became the first to obtain a PhD degree in neuroimaging, which is in 1990. So his achievements are enormous. So a few of them I'm going to just mention now. So he's a former president of Telemedicine Society of India, the Neurology Society of India, and also the Indian Society of Stereotactic and Functional Neurosurgery. And he was also adjunct professor at IIT Madras and Anna University, and he was an honorary consultant and advisor in neurosurgery, armed forces medical services as well. And during his journey, he has been editorial member to a lot of international and national journals. He has written more than 100 scientific papers, different articles in magazines and chapters in textbooks. And he's also a former member of advisory committee in the Department of Science and Technology, TST, Government of India. And currently he's a member of BIREC committee to review the proposals for the funding. And Columbia University has selected ATNF as a case study to demonstrate global best practices. He was also on the WHO roster of experts on digital health, and he's on the board of director of the Apollo Telemedicine Networking Foundation and Apollo Telehealth Services. And today's talk will be moderated by Professor Amitabha Bandyopadhyay. So Professor Bandyopadhyay obtained his PhD degree from Albert Einstein College of Medicine in New York. And after his PhD degree, he joined Harvard Medical School for postdoctoral research, and then joined IIT Kanpur in 2006 as a faculty. And currently, he's a Ken Chair Professor of Entrepreneur and Innovation at IIT Kanpur, and the current head of Biological Sciences and Bioengineering faculty of IIT Kanpur. So carrying out a lot of responsibilities. So he's also chairs the R&D task force at the Gangwal School of Medical Sciences and Technology at IIT Kanpur. And since January 2021, Professor has become a member of National Startup Advisory Committee. And he is also member of a lot of national committees to advise and oversee the startup ecosystem in India, and particularly targeting healthcare startups. So today's webinar will be co-hosted by Dr. Sushila Venkatraman and myself. And for audience, so please post your questions in Q&A box, and that will be taken up during the discussion. So over to Dr. Ganapathy.
Good evening, everybody. At the outset, I wish to thank the organizers for giving me this opportunity to share with you some of my thoughts on how I think healthcare is going to happen in the decade or so. I'm assuming you are able to see my slide. Now, before I go into technology in the healthcare proper, let's spend a few minutes seeing how the world is going to be in 2030. Continued economic growth, a population of 1.5 billion in India, aging populations in the developed world. Most important, new technologies will be more and more effective without any adoption lag. Interestingly, a CIA report, according to the media, has foreseen that India and China, probably a new entity called Chindia, is going to be the scientific and lead the scientific and technological supremacy in this part of the world. Now, we need to understand that futurology is a pseudo-science. Now, this is a pseudo-science where we extrapolate the cutting-edge technology today. So, ladies and gentlemen, I'm going to take you with me on a journey. I'm going to put you on a time machine and take you with me on a journey which I'm absolutely sure most of us are going to actually experience. Yes, there will be some hiccups on the way, but I guarantee you a safe landing. How is India going to be in 10 years from now? As per projections, everything looks very rosy. The annual gross household income is certainly going to increase. The elite, as we know them today, is going to increase by 2.3, the affluent by 2.1, the next billion, and so on and so forth. Even those below the poverty line is going to reduce to 0.6 of what it is now. So this is the world we are going to live in. This is all taken from the literature, but I just want to give you an idea before we go into the core of my own subject. Imagine a country where highways will be designated as driverless vehicles only. I don't think this is going to happen in India. But what is certainly going to happen in India is liquid biopsy, where a sample of blood can be used not just to identify the response of a tumor to radiotherapy or even chemotherapy, but even to make a diagnosis of most tumors in the body. When I was a postgraduate and even when I was teaching postgraduates, if I had mentioned that urine examination will help me diagnose an arteriovenous malformation in the brain, I would have been assigned to the nearest mental hospital. But this is what is going to happen. Satellite network, satellite coverage is going to be unbelievable. And again, it is foreseen that paper currency, as we know it today, will become less and less. Digital payments will be the norm. Marijuana has already been legalized in 50 states, and it is quite possible that many restaurants will use a 3D food printer. So this is the sort of world we are going to live in. Now let me go to the core of my specific topic. Medicine is going to be divided into what we call P4 medicine: predictive medicine, preventive, personalized, and participatory medicine. We are all aware that predictive analytics is changing the entire scenario, but we need to understand and remember that analytics is only as good as the quality of the data which is being analyzed. With the imminent practice of digital health, with EMR, hospital information systems, etc., the recording of medical data is going to be as it never was before. Preventive medicine. A huge organization like the Apollo Hospitals, which is a dividend declaring company, they have publicly mentioned that in the future, not in the future, today, right now, the emphasis is on reducing physical footfalls to the 72 hospitals which this corporate group has got. Preventive medicine, keeping you healthy, that is going to be a doctor's primary prerogative, not to make a diagnosis and treatment. Personalized medicine. Genomic studies are now available in almost all Tier 1 cities, and I predict that in the next 10 years, Tier 2, Tier 3 cities will also have genomic studies available at an affordable rate. This is going to change the way medicine and healthcare is going to be practiced. I will talk about this in detail a little later. When I was a house surgeon and a postgraduate, it was a doctor alone who decided on the entire healthcare of his patient. Already we have seen it is changing. Participatory medicine is P4 medicine. This allows an individual to participate in his or her own health, modify lifestyle diseases, and so on. Now, one of the most fascinating things which have been taking place is the close merger of technology and healthcare. It is unbelievable to realize that today electronic equipment, electronic prosthesis can communicate with the God-given brain and the spinal cord. The diagnostics has become so sophisticated that today we are able to extract the what I call the buy button, for example, in the brain. When you see an ad in the TV, you retain, you're able, it registers, retains, recalls. But then this needs to be translated into an action. Today, electrical technology has become so sophisticated, we can extract all this, and there are studies going on now. FDI has just approved preclinical and clinical trials where you wear a cap, and this cap amplifies electrical signals from the brain, communicates it to a laptop. The laptop can read the victim's thoughts actually and instruct the muscle in the thigh, the ankle, and the hip to move. This is what you and I do on every day. But remember, our spinal cord communicates with the God-given muscles. Today, the spinal cord and the plexuses and nerves can communicate with synthetic, artificial, electronic technology. Elon Musk is making waves wherever he goes. It is not just electric car. He has been persisting on this Neuralink, though the FDA originally did not give permission. Just recently, the FDA has given permission for very selected clinical studies. In fact, the advertisement has already gone out asking for volunteers. So brain-human interface is no longer fiction. This is actually happening. Here is a paper published in a peer-reviewed journal, New England Journal of Medicine, one of the most respected medical journals in the country. Just imagine this, a neuroprosthesis for decoding speech in a paralyzed person. A paralyzed man in Australia tweets using his mind after having a microchip implanted in his brain. The day is not far off when one will be able to get into somebody's brain. I have all these years been advocating that as a clinician, I need to get into the brain of my patient, understand what my patient wants, empathize with my patient, sympathize with my patient. But I never thought this is how it is going to happen. And in the years to come, we can literally understand and study the thoughts which is available in the patient's head. Space technology, again, NASA has made major contributions in many of these devices. You can see here a device, again, which is totally operated by the human brain and the spinal cord. Now, just look at what this slide says. One brain can only do so much, but if you can bring many brains together, directly connected in a network, it could be possible that they create inventions that no single mind could think of by itself. Today, through the internet, through high-speed internet, 5 of us could work on the same problem, and now what do? We have multi-point video conferencing. I look at a slide under a microscope, I communicate with a specialist in another continent and tell him this is what I think should be done. Virtual tumor board meetings are now relatively commonplace. But in the years to come, what is going to happen is the thought process, the electrical activity generated by a particular thought can today be identified, and using reverse engineering, once I have a particular type of electrical activity, it is not very difficult to say that this is the thought process. So in real time, when I say real time, I mean literally real time. Imagine if all the brains, if all the professors of IIT, All India Institute of Medical Science, Madras Medical College, etc., get together and work on a project. Imagine what could happen in the real world. Augmentative surgery is something unheard of, excepting in the last few years. I never in my wildest dreams would have thought that my student would be spending his time not on operating on brain tumors, on head injuries, and various other God-given problems which I did, but my student will be operating on trying to make a normal person smarter, a normal person run a mile as fast as Bolt can do, and so on and so forth. Deep brain stimulation now is available in at least 15 to 20 tertiary care centers in the country. The day is not too far off when we could even use deep brain stimulation to selectively stimulate small areas. I'm talking of 1 cubic centimeter in a brain with 1,400 cubic centimeters. You could precisely identify it and perhaps even use it as a Viagra. When Pfizer introduced the drug Viagra for impotence, it would never have thought that neurosurgeons could compete, and this could be used in the management of impotence as well. Contact lenses for taking videos, earbuds, which act as a universal translator. And much more practical, down to earth, is what is called the exoskeleton or exosuits, which you wear on top of your body, which will increase the physical strength. Now, this is what is going to happen. Eye scans now these raise very ethical issues. I'm not sure whether I would like a scientist to look at my retina through an ordinary ophthalmoscope and then using AI predict that 7 years from now, 8 years from now, there's a very strong possibility that I could develop Parkinsonism dementia complex. Apollo Hospitals is already tied up with Microsoft and Google. Several other corporate hospitals are also doing this. And today we have ongoing clinical studies which try to correlate the fundus picture using detailed analysis of different layers of the retina and cardiovascular disease. I predict that this will be standard clinical practice in 10 years from now. Examination of the retina is not going to be done by the ophthalmologist for eye problems, but will be done by the cardiologist, by the neurologist, and probably other specialists as well. So remember, when Shakespeare said the eye is a mirror of man, he was actually foreseeing what happened 5 centuries later. If I had said that A group and B group are compatible when I was a medical student, or even when I was a professor of neurosurgery, I would have been thrown out, ostracized, and removed from every medical association of which I was a member. Ladies and gentlemen, today it is possible with immunological tests to work around the problem of ABO incompatibility. To my knowledge, at least 15 to 20 in Chennai alone, 15 to 20 transplants have been done, kidney transplant mainly, 1 or 2 heart transplants and so on, where they worked around the ABO incompatibility. Fundamentals which we were taught, we have to re-look at these fundamentals. A pig kidney transplanted in a donated body. Would you really have thought that it is possible with immunological drugs available today to make an animal, a totally different animal, function effectively, efficiently? Of course, we have a long, long way to go, but nothing is impossible. Who knows, maybe in 10, 20 years, a pig kidney could be transplanted into a human. But then this is not going to happen because, as you will see in the next few slides, 3D printing, making a kidney in a supermarket is going to take place much faster and quicker. We are all familiar with Dolly. We all know how the sheep was cloned. The person who cloned Dolly died just a few weeks ago. Just look at this. And this is an article published in no less a journal than Nature. In fact, yesterday I was giving a talk on the United Nations General Assembly Scientific Mission. There was a full session on space medicine, and the moderator pointed out that though we have problems we're working around them, she said colonization of the moon is likely to happen in 20 to 30 years. The first trip to Mars may take place in 10 years. She raised a very important point of producing a baby in microgravity. Now, the answer which I gave was producing a baby on Earth is going to be totally different from producing a baby even in low Earth orbit and in microgravity. But why do you need the good old-fashioned conventional way? Already, pluripotent cells, totipotent cells from a skin, from a buccal smear, from the epidermis. Can you imagine this? From the epidermis, they have been able to produce an embryo and bring it up to 3 weeks. I'm talking of a human embryo. I'm not talking of an animal. A human embryo has been produced up to 3 weeks without using a sperm, without using an egg. Fertilization itself was not required. The implications, the ethical implications of this are unbelievable. And if this can be done in 3 weeks today, maybe in 50 years from now, it could be possible that you could produce, I don't know, a 6-month fetus, who knows, even maybe a full-grown human being in about 40 or 50 years from now. 3D printing, there are at least 3 companies which I am aware of, which already are in the ISS, the International Space Station, orbiting at a height of 400 kilometers above the Earth. As most of you know, there are at least 350 astronauts who have been living in the ISS for the last 20 to 25 years. And it's a matter of great pride that the Prime Minister of India has announced that the next time the ISS, somebody will be an astronaut from India. And India itself is planning to launch its own ISS in 2035. Of course, it could get delayed, but the plans are already on the drawing board. So 3D printing, there are many studies which have shown that functionally active liver, kidney, the heart, you can't think of an organ more complex than the heart. But this has already been done. 3D printing is being done. And these hearts which are printed in the laboratory are just able to work for a couple of days. In microgravity, there is enough theoretical information to show that the chances of it succeeding is far higher, and the ISS is already going to have this to happen. Now, let's come back to the real world. What happens in the real world? Today, we are all aware of GPay, we are all aware of digitization, UPI, even foreign countries have now accepted the UPI. So everything today is digital, and most of us use credit cards or some form of digital transformation. The next time somebody goes to a bar or buys a little more alcohol than we normally does, Big Brother notices immediately, and you could see potential symptoms of depression. A lapse in a gym membership of an obese person, potential risk of diabetes and heart attack is increased. Purchase of cigarettes by an asthma patient. When I purchase cigarettes in a supermarket and pay for it in a credit card, the credit card company knows entire history, not because it's interested in my health at all, but the credit card company has a tie-up with a health insurance company, which purely to reduce their expenses do not want to settle my bill if I get admitted for COPD or other respiratory conditions. And therefore, ladies and gentlemen, next time I go to a supermarket and I just look at a Baskin-Robbins ice cream and I want to buy, within seconds, I get a vibration in my smartwatch. My smartwatch tells me, hey, look, you forgot your cholesterol is so much, your HbA1c is so much, your lipids are so much, etc. Don't buy this ice cream. Instead, go another 100 meters, 20 meters, turn to the left, turn to the right, and you will get boiled vegetables, which is what we advise. This is not science fiction. This is already happening in a few trials. You can always argue invasion of privacy, but interestingly, the people who are driving this are the insurance companies purely from an ROI point of view. The next time I go to a shop and I purchase a 46-inch or a 44 size collar instead of the 42, which I was purchasing all these years, a message immediately goes and it says I require weight management because obviously I put on weight. Decreased frequency of drug refills is shown on my card. You can use your imagination and extrapolate this as long as you want. IoT is now being replaced by IoMT, the Internet of Medical Things solutions. Most corporate hospitals in the big cities are already doing this. Most corporate hospitals today have RFID trans-frequency chips on their wheelchairs, on their stretchers, on laboratories, of course, on the patient's wristband. So today, on a central monitoring console, we know exactly where the stretcher is, where the wheelchair is, where the patient is, where the particular diet which you ordered as it left the kitchen, tracking. You are not tracking courier services. Today, it is possible to track courier services in great detail. Similarly, we are tracking this in hospitals as well. The same technology, smart hospitals, smart rooms, smart beds. The message is don't work hard. I mean, that's wrong. I'm not saying don't work hard, but what is more important is work smart, not work hard. And the interplay of technology in the pure housekeeping affairs of running a hospital today is unbelievable, and that is what is happening. The metaverse. Again, I'm very happy that the institution I work with has got South Asia's largest simulation center in Madras. It's about 9,000 square feet. And now the National Medical Commission of the Government of India has made it mandatory for every postgraduate student to spend at least 3 weeks in a certified simulation center. We are not talking of augmented virtual reality. We are talking of extended augmented virtual reality. We are talking of quantum computing. We are Today, what took me 40 years to learn, having made hundreds of mistakes, I'm sure, like most of my contemporaries, many people were injured. Some of them may even have lost their lives because there was no other way for us to learn. Today, ladies and gentlemen, you will not, 10 years from now, it will be considered malpractice if you enter the OT and operate on a patient without having done a detailed simulation in the simulation lab a day or two earlier. And when I say simulation, I'm talking of that particular patient, his CT, his MRI, his angio, his X-ray, his metabolic parameters. If he had a myocardial infarction 6 months before, my computer will tell me that his myocardium, his ejection fraction is working at 88.9% efficiency. My computer will tell me if I've extended the incision by 2 millimeters, that I've in the process cut the facial nerve, and this is how my patient will appear post-operatively. This is unbelievable, and what is very gratifying is that this has slowly started happening in all the big national institutes of the country. We were all trained on cadavers, and training on cadavers, even I belong to the BC era, before computers and before Christ are one and the same. When I was a medical student and a postgraduate at the most prestigious Madras Medical College, the oldest and biggest medical college at that point of time, believe me, there was not a single computer in the Government General Hospital or Madras Medical College. Today, we can learn much more by dissecting electronically than I learned when I was in the anatomy department. When I dissected, obviously there was no bleeding. Today, when I dissect, there will be bleeding, cerebrospinal fluid will come out. I learned not anatomy, I learned pathology, I learned physiology, I learned biochemistry, I learned clinical medicine. I learned everything there is about that particular dissection, which I did without any idea, any knowledge in the anatomy department. On the right-hand side, you can see virtually, this is what the surgeon sees. Before the abdomen is open, he's now getting into the abdominal aorta, and there's an aneurysm of the abdominal aorta. This is what he had already seen yesterday when he goes into the theater, and this is projected as a holographic 3D projection. Surgeons of today will all be wearing AVR glasses. This, of course, did not commercially exist. A robot drawing blood, it's a relatively very simple procedure, but I don't think this became commercially viable. How many of you know that the commonest cause for a 50-year-old, 60-year-old, definitely 70-year-old getting seizures or complications of diabetes, hypertension, and so on and so forth is not due to the primary pathology, but is purely due to lack of compliance and adherence. It is not people with Alzheimer's alone who forget to take medication. Above the age of 60, 65, 70, every one of us by age-related changes do occasionally forget to take medicines, and this is a great area to be working on, where with very simple Bluetooth-enabled dispenser, the Bluetooth sends signals to your pharmacy and tells them that the drugs are over and that you need to buy a new set of drugs, etc., etc. Millions of dollars, maybe billions, not millions, billions of dollars are now being spent by pharmaceutical companies across the world to develop the magic poly pill. Studies have shown that when, particularly in the senior citizen, if he has to take 8, 10, 15, 20 medications a day at divided doses, different times a day, some once a week, and so on and so forth, adherence and compliance will significantly drop. If you just think about it, if you can have that magic poly pill, one single tablet, which will be anti-diabetic, anti-convulsive, anti-that, anti-this, antibiotic, probiotic, and so on and so forth, one single pill with a sustained drug releasing mechanism, so that one pill you take maybe once a week, once in 2 weeks, most of us will be willing to pay 100 times of what we are paying now if we can have the comfort of this. So this is the future. This is what is going to happen. Whenever I see the photograph on the left side, I think of my great-grandfather, though I do not remember him. I'm almost certain my grandfather perhaps was one of these people traveling on the train. But I'm equally sure that the photograph on the right, my grandsons, One of my grandchildren will certainly be staying in the 95th floor or 115th floor in the next 15 to 20 years. This, ladies and gentlemen, is India, the superpower which already is starting. And what is going to happen in these high-rise apartments with 400, 500 flats, 2,500 people living? You will have a single room. And in that room, as I'll show you in a few minutes, you will have a portable, pocket-sized ultrasound, X-ray machine, a POCD, point of care diagnostics, etc., etc. A hospital in your pocket, a doctor in your pocket, a laboratory in your pocket. All these are now taking place. They are still proof of concept validation pilot project. It's just a question of time before they actually come into being. 5G, India is going to be one of the leading countries in the world if we achieve even 50% of what the government is planning to achieve in the next 4 to 5 years. Many hospitals have already started doing pilot projects, and it's not on Netflix that you see cops having body cams. If you see some of the paramedics in Calcutta and in Hyderabad, you will see they're all wearing body cams. The paramedics are connected. Pre-hospital management. There will be a full-fledged department of pre-hospital management. The emergency department, which we know now, the paramedics and the hospital, etc., they will be doing much more. Thrombolysis will be initiated at the patient by the time the patient is put on a stretcher and moved into the ambulance. Through 5G and through various other mechanisms, we will be able to tell the very highly trained, sophisticated paramedic what is to be done. We have a Tele ER platform. Onboarded cameras will enable experts and command centers to advise the team in real time. Every emergency, the appropriate specialist can theoretically appear on a big screen inside a moving ambulance. Of course, part of this is certainly media hype, but nevertheless, it's a fact. Though I am an old-fashioned doctor, I still wonder why this patient in Gujarat, Ahmedabad and Gandhinagar, it was 20 kilometers away. I don't know why the patient could not physically have come to Ahmedabad from Gandhinagar. Whatever it is, it has been shown that the technology is available today. It doesn't matter where the surgeon is. He can be in another continent. And believe me, studies are going on where a surgeon will necessarily have to be on Earth, and an astronaut 200 kilometers above the air will be guided, will be told, handheld, and asked what to do. Robotic surgeons, NASA has already got a huge team doing this, and it is expected that in the next 10 years, the first emergency in surgery for space may need to happen. Wearables is a fantastic commercial market, and I'm delighted that many IITs, the Coimbatore Institute of Technology, I know for certain in Coimbatore, many institutions are working on this smart textiles, and I do know that the Indian Army also is trying out this in Kargil and various other areas. So wearable health monitoring systems of an unexpected level of sophistication. This slide actually should have come before, along with the cadaver slide. Imagine wearing a t-shirt with QR codes. And if you have, obviously, this t-shirt will be very expensive. And all you have to do is to focus on the QR code, and you will be able to peer into any part of the body which you want. These are all just becoming available. It's only a question of time before all this becomes available in this country. Now, I am talking of the future, but I believe that it's easier for me to convince you that many of these things are going to happen when I show you that in the real world, we are having pilot projects, we are having proof of concept validation. This is a project which was given to us by the World Economic Forum just 5 months ago in Meghalaya. Meghalaya whole population is 7 million people. And using state-of-the-art technology, we are doing a screening of 200,000 people in the most difficult areas, in the mountains and the tribal areas, using smart AI-powered handheld devices for the equivalent of a screening for a mammogram. We are able to do oral cancer, cervical cancer, and as you can see with some of the photographs on the right, we have already picked up a significant number. Every one of these patients are seen by the appropriate oncologist. on the ground. Can you imagine? In the remotest part of Meghalaya, a surgical oncologist from Madras, Hyderabad, Delhi is able to peer into the interior of the tonsils, do a cervical colonoscopy, and advise a paramedic, a nurse, what is to be done. So this, ladies and gentlemen, is going to be routine 10 years from now. I foresee that mobile medical units, as you see here, today we have less than 100 of them for a population of 1,400 million. Where in the world do you have a 3.5 kilogram? Of course, there are many places in the world. I'm saying this just to emphasize that it is extremely uncommon, and we are just starting on this project again in remote parts of Gujarat. You can see the backpack on the middle of the screen on the lower part. This X-ray machine, FDA approved, European Commission approved, Atomic Energy Commission of India approved, 3.5 kilograms weight. You take it, and just like you use a camera, you take a photograph, and lo and behold, the chest X-ray appears on your laptop. It is sent instantaneously to a radiologist who, with the help of AI, is able to pick out a lesion even if the human eye cannot be able to see it. And to me, this is unbelievable. I belong to the era where 20% of brain tumors, we called it intracranial space-occupying lesions, when I was in training in 75 to 80, were tuberculosis of the brain. In my lifetime, I'm absolutely certain, if we could, with the help of all the people listening to this program, you are a powerful group of people. If you can't help, nobody in this country can help. If we could multiply this pilot project 100 times, I'm very sure that in 10 years from now, the last case of tuberculosis in this country, we will be bidding farewell to them. And why? Because we no longer need to examine the sputum for AFP. Today, it is possible to test the DNA. Can you imagine? The DNA of Mycobacterium tuberculosis with a 99% specificity and sensitivity using a polymerase chain reaction test. And this was developed during the COVID. India did amazing work in PCR testing during the COVID. The same system, the same similar thing, TrueNat is what it is called, and we are going to use this, and we are starting this program in just a few weeks from now in 2 remote areas in Gujarat. BIRAC, Department of Biotechnology, these are just a few illustrations. We have been funding more than 600 digital health projects, and it is wonderful to see Make in India for the rest of the world. This was our motto, Digital India. The VR simulator, virtual reality simulator for acute cardiac life support, and so on. And it is a very, very gratifying for those of us involved in this to see that many of the projects which have been sanctioned have ended up in market, and it's just a question of time because this will replace what at present is being imported. Now, just look at this. 10 years from now, culture sensitivity as we know it, urine for culture sensitivity, a wound swab, diabetic ulcer, these photographs are self-explanatory. What do we do now in most of the places? We take a swab, send it to the laboratory, minimum 24 hours, 36 hours before we're able to grow the organism, find out the antibiotic, etc. Till that time, the doctor empirically starts on antibiotics, leading to the development of antimicrobial resistance. But here, these young boys, I'm sure Professor Amitabha is going to talk about this, people people like him are leading. They have developed a device which shines ultraviolet, visible light, infrared, near infrared, captures multispectral images in 60 seconds. An AI algorithm tells you which staphylococcus or streptococcus or Escherichia coli, whatever it is, which organism absorbs which light and reflects which light, etc. It tells you about tissue oxygenation, wound dimensions, everything. You get a printout. You can see a sample report on the right side. These have all been funded by BIRAC. Clinical tests are just being started, and if everything goes well, in 2 years from now, this will enter the market. Before I hand over to Professor Amitabha, I just cannot resist the temptation of saying how wonderful it is that the IITs, the Indian Institute of Science, the leading institutions in this part of the world have all realized. Of course, they did realize this 2 decades ago, but now they are implementing it. And we are having a School of Medical Science and Technology, a Department of Medical Sciences in Madras, in Kharagpur, in Kanpur. The IIC Bangalore will be the first to offer a formal MD PhD program. Not pseudo-scientists like me who got a PhD many years later, but an MD PhD program, a 7-year, 8-year program for MBBS candidates. So I now would like to hand over to Professor Amitabha and to give us his views as see, people like him, I think, are making a great difference. It is not clinicians, it is not medical doctors like me who alone can play a part in healthcare, but biologists like him, human biologists like him, and the sort of group which he leads. I think they do a wonderful job. Over to you, Dr. Amitabha.
Yeah, thank you, Professor Ganapathy. Exhilarating talk so far. I will first, put to the audience one rather controversial view of mine. I would love to know your reaction. See, like this move that is happening, engineering colleges opening up medical schools. Some may say that this was there in the US a long time back and we are only now catching up. I will tell you this, that my PhD and postdoc was entirely in medical schools, 12 years. And I was thinking back that how many times have I heard about engineering application in medicine or cross-disciplinary talks. When I am in a genetics department, I have only heard genetics talks. So I have a controversial view that if us scientists, if you allow us to form a comfortable peer group, then we love to work within a silo. Only when we are forced by smaller number, we will reach out. So I think that the experiment that is happening in Indian technological institutions will have a very different outcome than what has happened in the US. Now moving on to what Professor Ganapathy was talking about, and I am certain that many of you may not have an idea. I saw some of the questions that how expensive will it be affordable. So a parallel movement is happening within the academic institutions, engineering institutions. I will give you the snapshot of what is happening at IIT Kanpur. So Indian Council of Medical Research reached out to us that this handheld X-rays are very expensive. We cannot afford it. Would you please make it for us? We did make it for them. It is now undergoing clinical trial. But more importantly, we took it one step further, and Indian Council of Medical Research gave us 1 lakh X-ray images, some of which are of tuberculosis patients and some of which are not. With that, that is our training data. With that, we are training our image analysis part to automatically predict which of the patients might be suffering from tuberculosis. This is being developed as part of Prime Minister's mission to eradicate tuberculosis by 2027. I completely agree with the question that, who will be able to afford it? It is absolutely correct that while in India we have medical tourism as a very profitable business, almost 80% of the population is outside of the formal healthcare system. As you heard from Professor Ganapathy, that efforts are being made to reach out to far-flung places within the country through telemedicine. It is being the conducive environment is being created through massive government funding. As I am deeply involved in many of these efforts, I can tell you that many point of care diagnostic devices are being developed with active government funding, which will reduce the per test cost by 1/10. And much more importantly, you will be able to take these devices to the villages and small towns, and from there the data can be beamed to government's e-Sanjeevani portal, which is the telemedicine portal of the government with data security and all those provisions in place. Now, where we as IIT Kanpur community, IIT community, where we can play a role is here. And I want to be emphatic that these engineering implements that are being developed, the primary customer is the villagers, who, even though it is 1/10 the price, they will not be able to afford it. And therefore, the only way out is for government to subsidize all of these as part of their primary health center efforts. Us collectively, if we can invest in development of many such devices, influence government in adoption of these devices as part of government's job, then it is entirely possible that the vision projected by Professor Ganapathy will be realized at a fraction of a cost. Professor Ganapathy talked about simulation center. I'll tell you that at IIT Kanpur, we are developing a digital twin of a heart, meaning it is a software which you can play like a heart, and you can perturb like what happens during many of the cardiac ailments. And this is being developed as an assist for the left ventricular assist device that we are developing, so that we can predict what are the parameters if tweaked in the LVAD, how the blood flow pattern will change, how the patient will suffer or not. So many of the things that Professor Ganapathy talked about, we are pretty much on course. And as a country, like I do have understanding of what is happening in other IITs as well, because I sit in many of these committees. But what is needed is massive community support. We are the most prominent support group in the country when it comes to technology. So if we put our weight behind these developments, I think we will be pretty much on our way. So with that, I would now again request Professor Ganapathy to start the remaining of your talk, and we will catch up with the questions afterwards.
Yeah, thank you. I've answered some of the questions while you were talking. I've answered some of the questions. I hope the people who ask the questions will be able to just give me a minute. Yeah, okay. Now, there was a question on AI. AI, as you know, is the absolute, it's also used as a hype now. But I would like to give you specifically 6 examples which is now being implemented right now. The nice thing is this entire training data, validation data, clinical application is 100% based on Indian data. And not only that, we have reached the stage now where hospitals from Dubai, Singapore, Canada, and ongoing discussions with the NHS UK and an organization of the US is going on. So right now, we are using this clinical AI in the diagnosis of COPD in a type of diabetes. You can see it here, the accuracy, pre-diabetes, COVID, COPD, and so on. So this is one specific example. Again, GPT is something which everyone is talking about. As I said, I am an old-fashioned 20th century trained person, but apparently now, right now, people are making use of this even for discharge summary generation, and certainly is going to play a major part in healthcare. About 5 years ago, I held a one-day meeting along with the National Research Foundation of Government of India in Bangalore. We held it in Madras on the use of drones. As was the case with telemedicine 24 years ago, everybody laughed and ridiculed. But in the last 1.5 years, enormous developments have taken place. And we have now successfully completed for the last 2 years a proof of concept validation pilot project. We have fine-tuned the dozens and dozens of problems which we encountered. We call this medicine from the sky, and the World Economic Forum has brought out a publication in which this was done. And right now, AIIMS, All India Institute of Medical Science, Rishikesh, are using it. We are using it in Meghalaya and Arunachal Pradesh. It looks like a paradox, but believe me, it's easier to send a lot of things by drones in these hilly mountainous areas than to send it by road. So there is a definite use case for the use of drones. Another interesting use case for drones is within a hospital, a huge hospital. Many of our hospitals are spread over 1-2 acres. The All India Institute of Medical Science, for example, which has thousands of beds and things like that. Drones can be used to take samples from one building to another building and so on. It's all the use case. Of course, there's always a risk of overkill. Now, since ISRO is in the news now, we are talking of Vikram. We are no longer talking of Chandrayaan-3. We are talking of Vikram. And right now, ISRO has not yet given up the possibility of waking up the rover which is on the moon now. So I just thought this would be appropriate, because this whole talk is about the future of healthcare. 4 years ago, I myself was surprised when the editor of Neurology India agreed to my request to bring out a special supplement. Can you imagine a so-called third world developing country like India? We are no longer that, incidentally, bringing out an entire issue on extraterrestrial neurosciences. And over the last 4 years, many of these papers have been downloaded several thousand times each. And I think it's a matter of that the Indian Air Force has already sent doctors for training. And even though at the Gaganyaan mission, there will only be 3 people in low Earth orbit for 5 to 7 days, still the health care for these people when they are outside the Earth's gravity is tremendous. Now, one of the terrific fallouts of the space mission is the butterfly. It's called the butterfly. This is ultrasound equipment which fits into your pocket, remote ultrasound. The quality is actually better than the huge ultrasound machines we use. Unfortunately, I don't know whether this will ever be available in India, because in India, the regulations are so strict purely because the ultrasound was misused to terminate female infanticide, as you call it. So because of that, the rules are extremely strict. But this is a direct fallout. And in most of the Western countries, in fact, the Lancet had a beautiful article about 4 years ago called The Obituary of the Stethoscope. And I foresee that 10 years from now, at least in the big cities, the big hospitals, nobody will be using a stethoscope. After all, a stethoscope is a surrogate decision marker. You hear sounds and you depend entirely on the subjectivity, on the expertise, on the intelligence, on the experience of the person hearing a murmur, hearing a wheeze, hearing a ronchi, and so on and so forth. Today, with devices like this, we can do an echocardiogram of the heart. I can semi-quantitatively and quantitatively, precisely, I can see the blood going from the atrium into the ventricle, the level of oxygenation, and so on and so forth. This is just an example of how in the ISS, International Space Station, as one of the part of the experiments, an astronaut was doing a Doppler on himself. He had no symptoms whatsoever. And to his horror, he found that the jugular vein had a big thrombus and a big clot. And of course, they consulted a local doctor on Earth. When you say local, I'm talking of a doctor on Earth. who spoke with the astronaut, and believe it or not, I don't know the exact details, but I do know the drugs were sent by a separate spaceship, by a separate rocket as it is called, and then from the ISS, they opened the door, got the drugs, patient was treated for 4 months outside the Earth, and he landed safely. The full paper is published in British, I don't remember, I think it was New England Journal of Medicine. So this is what we are. Now, this came in the news just a few days ago. I think this is something to be justifiably proud of. We are able today to make a hospital like this at a fraction of the cost of what is done in the US. And this can be brought together whenever there's a natural disaster or any other disaster. In an operation theater can be set up in 10 minutes with indigenous ventilators, indigenous operation lights, and so on and so forth. Rechargeable solar generator, you name it. 200 survivors can be accompanied in this for 48 hours in this. So this is the world's first portable hospital. I cannot help by concluding the last 2-3 slides by concluding with problems. So far, I was very excited, or rather, I was trying to tell you what technology is doing. Let us, good and evil are two sides of the same coin. So let us see what can happen. Again, this was a report by an MIT professor. We generally assume that the MIT is one of the world's leading institutions. Again, the original paper was published in a peer-reviewed journal. Today, Drosophila melanogaster, which is a fruit fly, the telomere, which is the end of a particular in the chromosome, as you can see it. Today, it is possible. It has been done for more than 30 years. They've been doing it. They have perfected it now. Today, it is possible to increase the lifespan by playing about with the telomere 100 times. A fruit fly's normal life expectancy is 24 hours. Today can live for 60, 70, 80 days. So if the same technology is used, people are of the opinion that genetic engineering may make it possible. Obviously, immortality is stupid, but I think my great-grandchildren born in a developing country like India certainly will all become centenarians. I was surprised when I was preparing for another paper to show that even in the last census, there were 1 million centenarians in India, 1 million people in India above the age of 100 years. Probably it is 2 million now. Now, what are the implications of all this? The well-to-do people believe that storing a body at minus 200 degrees centigrade a day may come 30, 40 years ago, where you may be able to thaw somebody who is stored in that and assisted dying. This is all happening. The Supreme Court of India, just in December last year, said that the right to die with dignity is a fundamental right. And this has radically changed now. The laws are very clear now. In India today, I have the right to make a living will. Of course, the administrative things are still complex, but nevertheless, assisted euthanasia is still a gray area, but is likely to come in India again. Now, what is the downside of this? Technology was used. This was accidentally discovered. Can you imagine how technology was used to publish substandard papers? A lot of citations were done. A lot of papers were quoted when such authors, the authors to whom these articles were attributed to, were taken aback when they were told they had no idea of all this was happening. So this is the other side. So before I conclude, I was surprised to see that a company, I mean, obviously it's marketing, but nevertheless, just look at this. The first telemedicine company on Mars, scheduled departure July 26. May not happen in 26, but certainly it is going to happen in 2036. If Moses were to come down to the earth again, every one of his 10 commandments would be prefaced by the word, "Thou shalt digitally transform." An analog world is already gone. Today, we are only talking of a digital world. Originally, engineering, science, medicine were all different. Then they were running in parallel. Today, they are converging. You cannot be a good medical doctor without having a good basis of engineering and science, technology, and the same with the other specialties also. So, ladies and gentlemen, you can ignore reality, but you cannot ignore the consequences of ignoring reality. We need to be optimistic. It depends on what you see in the mirror. This little kitten doesn't see itself, it sees a lion. And I think it is time that all of us start doing all this. I would like to conclude in a very philosophical note. And you can, as I mentioned in the very beginning, I am in the old-fashioned BC doctor, a doctor trained in the BC era, before computers and before Christ. There has to be a difference between me and my cousins. The only disease transmitted from humans to animals is this addiction to mobile phones. You can see this, my cousin on the right-hand side, playing about with the phone, and on the left-hand side as well. There has to be a difference between me and my cousins. And therefore, what is important is, as a medical doctor, as a clinician, I feel sad that the day may come where people will only be interested in whether AI was used, ChatGPT was used. Today, or rather yesterday, okay, maybe even today, tomorrow is different. Today, most patients do not care what you know. They don't care if your doctor is a PhD, whether he's got articles published in Nature. They don't want to know his citation index or his H index. They only want to know how much you care for them. What is the care you are giving? That is all. And therefore, I am afraid, I'm concerned that the doctor of the next decade, of the 2 decades from now, may totally forget the fact that it is possible to wipe the tears with tender loving care, albeit virtually. Today, looking on a screen, when I give a teleconsultation, I still spend the 3-4 minutes more listening to the patient. Listen. He's telling you the diagnosis. What the patient wants today is not necessarily the most sophisticated AI algorithm. I don't want to know whether I'm going to get Alzheimer's 12 years from now. I want the doctor to sympathize with me. I want him to understand what my problem is. And even if he cannot open the anterior inferior descending branch of the left coronary artery, I want him to at least tell me, reassure me that everything will be fine. So I think this is what is important. We need to develop a website manner, which is as important as developing a bedside manner. I could go on and on, but I think I'll stop with this. So thank you once again for giving me this opportunity. Hello.
Thank you, Professor Ganapathy. So there are some questions. Now, instead of typing, you can answer them live. And the first question from Mr. Rajendran is actually a very, very valid one. Is that the way healthcare is going, the amount of data being generated, being stored, analyzed, this is obviously, like I'll tell you that a few years back, this I teach in my course, there was a proposal in UK that everyone's DNA will be sequenced and the sequence will be made available to insurance companies, and insurance companies can give preferable rates to certain people. So there are many ethical issues that come up with this digital transformation. Where, as a practitioner, you stand on this?
Sorry. Could you just repeat the last one? I was just typing out the answer. My apologies. Just the last sentence, sir.
That you know, what is your assessment of the risks associated with digital transformation in terms of data privacy, data security, and antagonistic insurance pricing? Yeah.
Okay, you have raised a very pertinent problem. Honestly, I don't know the answer. I don't think anybody will ever know the answer. The other thing is we need what is called a test case. Having said that, I feel that we are sometimes a little paranoid about privacy and security. I mean, to put it very crudely, who the hell is interested in knowing whether I'm HIV positive or not? So I think that if we wait long enough for privacy, security, this, everything to be perfected and sorted out, we will be losing tens of thousands of lives. You can't learn swimming until you get through a postal course. You have to get into the water. So I would rather start on all this and develop privacy, security, insurance, etc. as we go along. Now, your point is very well taken that insurance companies in Western countries have already started denying people insurance claims, or rather not allowing them even to give a premium, because science has predicted that the unborn baby may have BRCA2-1 gene, and this unborn fetus with a 99% probability will develop a cancer breast when she becomes 19 years old. Now, this is mind-boggling. This is already available. So these are going to be major problems, but I'm still optimistic that I know the government of India has been thinking about it for a long time. Singapore has solved the problem. Singapore, of course, is about 5 million. 300 Singapores make India, but still, I think we should have, like we have an education tax. When the education cess was introduced, people complained, but nobody complains now. I think if they have a 0.25% health tax, as they do in Singapore, in Norway, in many European countries, we will raise enough funds, cross subsidy as we call it. 1,500 million people, each person pays 2 rupees a day. We get 3,000 million rupees a day. I mean, you need to do the exact match. But what I'm saying is cross subsidy at any given time, not more than 5% or 8% of the countries need to healthcare. One of the members of the audience was raising the cost about concern about cost. Sir, I would like to tell you that I'm sure you and I do not want to travel in a cheap Boeing to some other country. There is a certain minimum level below which you cannot reduce the cost. We need to understand that MRIs, PET CT, PET MRI, etc. are going to be expensive by today's standards. The solution is not to make cheap MRIs alone. The solution is to get a cross subsidy so that every individual has an insurance coverage. Insurance coverage is tremendously increasing in India in the last 20-25 years. But the day when we reach 95% insurance coverage, I think it will be cost effective and totally viable.
Okay. Mr. Rishi Sharma asked, what is the most important challenge or area of improvement that is seen today in the path of health innovation and its adoption in India? Like Dr. Ganapathy, with your permission, I will take the first shot and then you please come back at it. See, our biggest challenge perhaps is the lack of penetration of the very high quality healthcare that is actually available in India. And there are government hospitals which many of us do not want to walk in, but I have had the good fortune of seeing some of these from the inside. They are really well equipped. They have top quality doctors. They're overwhelmed with the number of patients. And many of these patients come to the tertiary care hospitals just because they could not take care of their ailment at an early stage, which you and me can, because we have access to doctors and path labs around the corner. So that is a challenge. If we can overcome it through the penetration of telemedicine, I would say that if we can achieve what we have achieved with payment, with UPI and BHIM and all of that in health sector, I think that will be remarkable. But I would like to know what Professor Ganapathy has to say.
I approach the problem in a totally different way, a low-hanging fruit which can easily be done. There is some data particularly from the United Kingdom which says that promoting health literacy, you will be amazed to know the degree of health illiteracy in this country, even among the so-called educated people. Patient empowerment, knowledge empowerment, promoting health literacy using modern technology. Today it is possible. Today it is possible to talk to 1 million people with a PPT, videos, animation, that, this, etc. in 35 different languages on diabetes, hypertension, cancer, that, this, etc. We have been doing this in a very, very small way, but then we are only able to reach a few thousands, tens of thousands. The government, according to me, or the appropriate authority, are not doing enough to patient empowerment and promote health literacy. Most of the conditions, it is very tragic as a neurosurgeon. Even today, in 2023, I see doctors, engineers, chartered accountants, judges, army officers coming to the emergency totally paralyzed because they had a devastating stroke because their blood pressure increased and a vessel ruptured in the brain. Nobody bothered to check his blood pressure. Nobody took drugs even when he was prescribed. I think we should go on a war footing, particularly because today India's problem is NCD, not cancer, not trauma, etc. And 90% of NCDs, the complications of NCD are 100% preventable. And most NCDs today can be diagnosed well in time and can be very well controlled. So the answer to my question is, to me, the greatest challenge and the one which needs to be addressed on a war footing, purely because it is cost effective, very little money is required. We need to promote health literacy and make people understand what their body does, how the body functions, etc. Health illiteracy is at an all-time high.
Yeah. Last question from Mr. Narayan is how is India processing on nuclear medicine?
Okay, I am not an expert and I may not have the 100% reliable answers, but my general knowledge on nuclear medicine and my interaction with nuclear medicine colleagues says that we are not at all behind any other country. See, India is a paradox. There's not a single investigation, and I can talk this with authority. There's not a single investigation, a single procedure, a single treatment available anywhere on the planet Earth which is not available somewhere in India. Of course, a PET CT, PET MRI may not be available everywhere. You may have to travel 200 kilometers, but certainly there are nuclear medicine in India, in the big hospitals. I don't think they're in any way more backward than in Western countries.
Yeah, I agree with you. I have seen the nuclear medicine both at SGPGI and at Apollo. It is state of the art. So, yeah, it is available. It is just the centers, number of centers at which it is available may be less, and we need to increase. We have now almost come to the end of it, and I will end with an anecdote that all of you who are associated with the IITs, you will like it. This is, I am quoting from last week only. IIT Kanpur has an earth science department, and a colleague there who has been working with technologies to detect architecture of subsurface rocks, etc. They use sound waves. So he came up with an idea that can this be used for medical imaging? And of course, we have one of the best medical imaging guys in this room, Professor Ganapathy. So yesterday we sat through a 2-hour-long discussion and realized that he has developed a technology that can potentially replace MRI, both in terms of power as well as resolution. And of course, because IIT Kanpur has such good collaboration with many doctors and Dr. Ganapathy, we will now have to bring them in to understand what is being claimed, how realistic it is, how it can be improved further. And if it is possible, then that's a massive game changer, because you are talking about a battery operated device sitting in village PHCs and can get MRIs done in situ. So with this optimistic note, I think that the IITs, IIScs, they're foraying into medical technology will make a massive impact. The impact that was not that discreetly visible in the Western countries, you will see that impact in India simply because it will be sudden. And of course, I am biased. I think it will be much more effective than the models existing in the West. So with that, I would now hand it over to Dr. Sushila.
Thank you very much. Years ago as a kid, when I read Fantastic Voyage by Isaac Asimov, I was absolutely fascinated. And today, as I listened to your talk, Dr. Ganapathy, I felt just as fascinated. Thank you for a wonderful talk. And Professor Bandyopadhyay, thank you for being the interlocutor and sharing your ideas and thoughts as well. Just a quick wrap up. We started by saying that by looking at the world in 2030 and also where India will be in that new world order. We looked then at some areas where developments are already ongoing, and that is things like liquid biopsy, 3D printing, and genomics, etc. Every one of these areas is transforming healthcare and completely changing the contours of what we understand so far. We as lay people going into a hospital or meeting a doctor, the kinds of things that we've seen so far, there's going to be a wide difference between that and what will happen and what is already happening. What is certain is that technology and healthcare are merging very, very tightly. And one of the things that Dr. Ganapathy said was that in the future, we are not going to see the good old stethoscope that has been used for many, many decades. He also then talked us through what exactly the doctor's role is going to be and how that's going to change, and what the primary task would be, which he said is really going to be keeping people free of disease rather than just treating. And then he gave us this concept of the P4 medicine, which is predictive, preventive, personalized, and participative, all of which definitely needs a huge amount of technology integration. We saw some lovely examples of how this is happening today in different parts of the world. We started by looking at the cap, which communicates and with a laptop, which then reads the victim's thoughts and then helps them walk and move their limbs and so on. So we saw many, many examples. One of the things that Dr. Ganapathy told us was that in future, before a doctor operates, a few days before a doctor operates on a patient, he or she would definitely have simulated that whole process. And therefore, it's going to be that much more accurate, that much more of, possibility of success. He also talked about things that have been happening in the consumer world for a while. So, the retail store example of don't look at that ice cream because you now have even retina readers. So someone's going to be popping up and saying, don't look at that ice cream. It's not good for you. We are already seeing the use of IoT, both in hospital management and on the patient in terms of patient monitoring. That has already started happening right here in India. So that is really not something that, that's something we should not be questioning and asking, is that something for a country like India at all? For training and simulation, the use of extended augmented reality, that is already happening here. There are companies that are doing augmented reality, virtual reality based training for different kinds of operators, technicians, as well as doctors. And then we've looked at the idea that a hospital, a doctor, a lab in your own pocket is not a thing of, it's not something completely imaginary. It is something that is going to happen. And then we looked at a lot of what is happening in India. And we looked at Tele ER, we looked at mobile screening, we looked at the tele ambulance, and all of these things are already ongoing. And we saw examples of all of that. So thank you, Dr. Ganapathy, for the examples, because that made it all come and made it real for us. In the next 10 years, he talked about emergency surgeries being performed in space and what is required for all of that. We looked at wearables. So, you know, a lot of that future that he talked about today is actually already here. And again, in terms of India, BIRAC supports over 500 projects already. They're funding and supporting 500 projects, over 500 projects already. The IITs and ISC are setting up medical, are going to be offering medical degrees, medical schools, and so on. The very fascinating example of the Arogya Maitri Cube for disaster and emergency support was wonderful to hear about as well. And then finally, we concluded by looking at the negatives, the ethical issues. For example, if the life of a fruit fly can be modified so that it lives much longer, since genetics very much comparable with the human genetics, will genetic engineering make dying optional? And what is the ramification of that for us at the social and other levels? I was quite intrigued to see one of the news reports that you had put there, which is that a US tech investor believes that they are close to a cure for old age, as though old age is a disease which just didn't fit. Anyway, so we talked about a lot of that, but finally he concluded by saying that the fundamentals remain the same. What used to be called the bedside manner is probably going to be now a combination of bedside manner and website manner. But it is really about the patient and keeping the patient front and center. And there's no substitute for tender, loving care, whether online or in person. And therefore, that is where really the doctor should focus. I was very happy to hear you talk about the importance of prevention of non-communicable diseases, Dr. Ganapathy, because you know that's the area that I work in. So absolutely delighted that you did make the point about how important that is for a country such as ours. So thank you very much for this absolutely fascinating session. Thank you to the audience for your questions and for your participation, for being with us. The recording of this video will be up on our YouTube channel come Monday or Tuesday. Please do feel free to share this with anybody that you think might benefit from it. At IITACB, we are looking forward to doing many such projects. So if there are folks who would like to bring projects to us, we're very happy to take them up as well. Thank you, and we look forward to seeing you on our next webinar.